Morning. Excuse me. Morning, everyone. Nice to see you all. Thanks for coming. And I've been asked to do a couple of things, which is kind of give a big picture overview of what's going on in healthcare generally, and then talk about the implications that has on models of governance and functional governance. In other words, the way that boards of directors have to change to oversee steering their organizations through these incredibly challenging times. And all you have to do is read the newspaper, and you'll see that healthcare is front and center. And I'll talk about why that's the case, and also talk a little bit about health reform and some of the implications of health reform, and get into a fairly wide-ranging area of topics, all of which speak to the very simple thesis, which is that organizations are going to have to change to remain viable to a radically changing economic environment. And then there'll be an opportunity for questions and comments a little bit later on. So, and I'll probably I'll probably divide this into two presentations, one on kind of big picture healthcare and the other on governance. So probably we'll open it up for questions if that's acceptable, Madam Chair, after the first presentation before we get into the second. And I know we have lots of members of the public here, so if I also want you to feel free to, if I'm going too quickly or if I lapse into healthcare speak, which is very tempting to do. It's its own language with its own set of acronyms, and I'll try to avoid those, but if I'm using an acronym which you don't understand, please just stop me and I will spell it out and explain it if I know what it is, because we're oftentimes guilty of using big words that we don't know what they mean. So let's jump in and ask a couple of questions before we jump in. First of all, health reform is very much on the minds of everyone today for a variety of reasons. And before we get into some of the political issues surrounding health reform, I think it's good to ask a couple of questions. Why did it pass this time? Health reform legislation is now about just over a year old, passed about a year ago. It's important to bear in mind the perspective of history. Presidents going back to Theodore Roosevelt have attempted to reform the American healthcare system. All have failed, with the exception of the Obama administration. So why did they fail previously, and why did it pass under the Obama administration? And it's important to understand that one of the reasons, and incidentally, before I answer that question, it's important to understand that the presidents attempting to reform the healthcare system historically have been on opposite sides of the political spectrum. Most recently in our history, President Clinton attempted to reform healthcare in '93 and failed rather spectacularly. And prior to him, Carter had a kind of half-hearted effort at it and backed away pretty quickly. But prior to that, President Nixon had the most aggressive health reform attempt. And I think we can all agree that Presidents Clinton and Nixon were on opposite sides of the political spectrum. And it's very important that if you take the politics out of it, what you're left with is one of the driving forces is economics. And so if President Nixon's health reform package had passed back in 1970, we'd be spending today about $1 trillion less per year on health care than we're currently spending as a nation. If Clinton's reform package had passed in the early 90s, we'd be spending about $400 to $440 billion less today than we're currently spending. And that then kind of gives an answer to the question, both why didn't they pass previously and why did it pass under the Obama administration? And the answer is, number one, previously they didn't pass because they didn't need to. The status quo was always an option. In other words, if health reform didn't pass, we, the healthcare industry, could keep doing things the way we had always done them without an immediate negative consequence to us or to the broader economy. And the corollary to that is one of the reasons it passed under the Obama administration is the status quo was no longer an option. We can't keep doing things the way we've done them, which is another important point because many people believe that health reform is evil and that it should be repealed and are in denial, and they believe that once we repeal health reform, if that is to happen, we can then go back to doing things the way we've always done it. And that's not going to happen. And it's important to understand why. Whether we have legislatively driven health reform or whether we have market-driven health reform, the American healthcare system cannot last as it's currently configured because it will destroy the economy of the United States. And that's a big, long discussion, so I'll just summarize it very quickly. Have any of you ever heard a presentation by someone like me who has shown, say, the graph of increasing healthcare costs relative to the economic, to the rate of expansion of the economy, or the graph of expanding Medicare costs relative to the rate of inflation? And the speaker would say, well, gee, if that keeps up, sooner or later, it'll fall apart. Sooner or later, the economy will collapse. And I've been making that presentation for 30 years, and it's been really interesting. For about 28 of those years, people would say, oh, you're crazy. You're being histrionic. You're being you're exaggerating. The American economy is the most vibrant economy in the world, and it's immune from such petty concerns as healthcare spending. What's really interesting is I don't get pushback on that concept in the last 2 years. I can't quite figure out why. Perhaps you could help me understand that. And that's because what we've seen happen is what is usually necessary for change, which is to reconcile an intellectual understanding with a visceral understanding. And intellectually, we understand that you can't have healthcare costs grow 3 to 5 times the rate of economic expansion in perpetuity without having economic collapse. But viscerally, we didn't believe it, or we thought that the economic collapse wouldn't be in our lifetimes, or we could keep kicking the can down the road. And then what happened in 2008, 2009 is we viscerally understood the fragility of the American economy as we are dealing with the worst economic crisis in just about 100 years in this country. And suddenly people begin to understand because their heads and their guts, or their heads and their hearts begin to be in the same place. And that's fundamentally one of the reasons why we're going to see change, regardless of whether it's driven legislatively or market, or what's probably going to happen is a combination of both of them. And that's because in consulting we have an old saying, if something cannot last forever, sooner or later it will. And we're at the point where it's going to stop. Healthcare costs have grown so fast, so far, for so long that they are destabilizing the American economy, especially at a point of kind of unprecedented economic circumstances, globalization, issues like that. And without belaboring the point, there are just a couple of 2 points to understand if you're thinking about macroeconomics and healthcare. The first one is the issue of balance. And that is, if you imagine the American economy as a pie chart, and you imagine the healthcare section of the American economy as one of the slices of the pie chart, the problem is that that slice has grown 3 to 5 times faster than the pie as a whole every single year. Doesn't matter how fast the economy grew as a whole, whether it didn't grow, whether it shrank, the slice that is healthcare continuously grows 3 to 5 times at the rate of economic expansion. So thinking about the pie, as that slice grows, it crowds out other expenditures. The more we spend on healthcare, the less we have to spend on other things, education, defense, research, infrastructure, whatever you think an economy should spend its resources on. So that's part of the problem. I'll give you an example. We just got the 2009 data about 3 weeks ago, and that showed that healthcare costs grew in 2009 at their lowest rate of growth in about 40 years, only 4%, only a 4% increase in healthcare costs, which is great. It implies that we have controlled healthcare costs. What did the American economy do in 2009? What was the rate of economic expansion of the GDP? Yeah, it was a negative. It was like a negative 0.2%. So I want you to think about that. Even at the slowest rate of cost growth in 40 years, healthcare costs still grew 4 times the rate of economic expansion. And that just can't happen. So that's one reason. And the other reason is a little bit more difficult to express and also to gather, because people who work in healthcare find it rather insulting. But the other reason is because healthcare spending does not add economic value to the goods and services we produce in an increasingly global economy. In fact, just the opposite, it consumes value. Meaning the more we spend on healthcare, the higher the cost of our goods and services relative to our economic competitors who aren't spending nearly as much on healthcare as we are. And that's based on how we tend to price the cost of our healthcare into the cost of the goods and services that we produce. So for example, and I'm sure you've heard these statistics, but the single most expensive raw material of a car made in Detroit is healthcare. If you buy a car made in Detroit, somewhere between $1,800 and $2,200 of the retail purchase price of that vehicle went to pay for health care, for the people who built the car, for their dependents, and most expensively for their retirees, which calls into, and we'll talk about that in a minute, as we think about some of the stuff that's in the front page of the newspapers today, for example. So if only Detroit made cars, that wouldn't matter. But now we're competing internationally with countries who make cars who don't price healthcare into the cost of their goods and services. So for example, in Japan, the most expensive raw material of a car made in Japan is steel. Only $200 of the retail purchase price of a car made in Japan goes to pay for healthcare. So just take that as an example and consider the implications. If the Japanese can produce a car at this level of production cost and this level of quality, and we can match their production cost and match their quality, our car will be $1,600 to $2,000 more expensive than theirs with no appreciable benefit, with no benefit to the end user. That $1,600 is not value added. It's just pure additional cost. And the problem is it's just not cars that applies to. Single most expensive raw material of a John Deere tractor or of a Caterpillar tractor made in this country is healthcare. Single most expensive raw material of a Daihatsu tractor is steel, and so on. So, and I could give you lots more examples of that, but I won't bore you with that because I have other things to bore you with. But if you play that out over time, you see the problem. So right now we're spending, this year we'll probably spend somewhere between 17.5, 17.7% of our economy on healthcare. And who are we competing with? You know, oftentimes we'll compare ourselves to, say, Germany or France, and they're spending around 12, 13%. So that shows a competitive advantage. But our real competitors are the emerging economies. China, for example, just surpassed Japan as the second largest economy in the United States. India is growing very fast. How much do they spend on healthcare? China spends around 4% of its gross domestic product on healthcare. India spends around 2% of its gross domestic product on healthcare. So they can produce things inherently less expensively than we can, simply because they don't bear the burden of healthcare costs and they don't price it in to the cost of their goods and services. So it's almost like we're in a race and we're running up a hill, and I'm the United States and I have to carry a 50-pound pack on my back, and China and India only have to carry 5-pound hand weights. So, and that's worthy of lots more discussion. You know, that's a whole big macroeconomic analysis and things like that, but the problem is that we are spending far more than anybody else. And healthcare is now beginning to bankrupt the nation. Just another quick statistic to put it in perspective. Right now we're in the middle of 2, 3, 4, I forget how many wars we're in the middle of. You know, Afghanistan, Iraq, Libya, a generalized war in Pakistan. You might even argue a generalized war in terror, but let's call it 3 wars just for the sake of argument. So we're in the middle of 3 wars right now. 2 of them we've been involved in for 10 years. And so you could argue that we're in something of a military emergency, and compare what % of our gross domestic product we're spending on the military during a time of war to how much we're spending on healthcare during a period of healthcare normalcy. And by that I mean we don't have some huge public health crisis in America right now. We don't have a very high mortality flu pandemic or some epidemic sweeping the nation. So right now we're spending about 17.5% of our economy on healthcare. What % of our economy are we spending on the military? Anyone know? It's about 4.9%. Okay, so I mean, and don't get me wrong, I would never argue, you know, that we should spend more on the military. But if you would ever expect military spending to eclipse healthcare spending, it would be in a period of, you know, of war. And to really drive the point home, consider the Department of Defense. What's the single fastest growing and largest expense that the Department of Defense has in the middle of these wars? Healthcare. Healthcare. It's not guns, planes, tanks, bombs. It's healthcare. So that's just an example. I mean, if you think about that, something ain't right. You know, so there's an imbalance. Something is wrong. And that then brings us back to the notion of why health reform passed this time. It's because people understand that we've got to fix it, otherwise it will just, you know, drive the economy to collapse. Now, before we get into the details of it, you know, it's important to talk about the big push to repeal or replace healthcare, because a lot of people think that it'll be politically repealed. And that's possible, but I really don't think that's very likely. For the bill to be repealed would require the Republicans not only to capture the Senate in the 2012 election, but they would have to capture 60 votes in the Senate. And probably also the White House. So certainly within the realm of possibility, but fairly improbable. The much more likely risk to the health reform legislation is at the Supreme Court level because of the constitutional challenges coming up through the federal courts. 2 judges have found the law, one specific provision of the law, to be unconstitutional, and that is what's called the individual mandate, the requirement that individuals have to purchase insurance. And people are arguing that, you know, you're regulating inactivity and that that's unconstitutional. And I'm going to make that argument in about 2 weeks when I don't file my taxes, by the way, and see how that plays out. So in fact, we have regulated inactivity. So it's an interesting argument. 2 federal judges have found it to be constitutional. And just again, from a historical perspective, the fact that a couple of federal judges have found it to be unconstitutional doesn't really mean that much. I'd point out to you, when Medicare legislation passed, about a half dozen federal judges found that to be unconstitutional. And when the civil rights legislation passed, several federal judges found that to be unconstitutional as well. The great challenge is that the bill itself does not have what's called a severability clause. And for any of you who've ever signed a contract, you know what that means. A severability clause basically means if any portion of this contract is found to be illegal or unconstitutional, it is severed from the remainder of the contract, and the remainder of the contract is in force. Most bills have severability clause. This one doesn't. And the Obama administration claims that the reason it doesn't is because the bill, you know, is so finely constructed that everything is inexorably intertwined and you can't pull something out without affecting the whole bill. That's not the reason. The reason is they passed it very quickly, expecting once it passed to be able to clean it up and pass a reconciled version, and they forgot to put a severability clause in. And then once it passed, they couldn't bring it back for a cleaner version because Scott Brown won the election for the Senate seat of Massachusetts, which had been vacated by Ted Kennedy, and the Democrats lost their 60-vote filibuster-proof majority in the Senate. So that's the real reason behind it. So the risk, however, is if the Supreme Court says, no, we find the we find the individual mandate to be unconstitutional, they could then technically throw out the whole bill. So it'll take about a year for the bill to get to the Supreme Court, so we'll see what will happen. It'll be quite interesting. But again, just a little bit of history, because you can see I'm a history buff and I appreciate irony. Anyone know who came up with the individual mandate concept? Anyone? It was Bob Dole in 1993. It was the basic plank of the Republican opposition position to the Clinton health reform package. So it's really quite interesting to see how, how issues change and how things change over time. And I'm particularly struck by that, by the Republican budget, which is in the front page of the newspaper today, which would cut Medicare substantially, and we'll talk about that in a few minutes. So that's a little bit of the background and a little bit of the economics. But there's another major economic issue which hasn't existed in this country until recently, and that is the huge federal debt, not just the federal debt, but what's called public debt, which is the accumulation of federal, commercial, and private debt. Which this country is dealing with. And we've only had a level of debt that surpassed this once in our history, and that was during World War II. And we were able to get out of it then using strategies which are not available to us now. Many people say, gee, we had a higher level of debt then, can't we just do the same thing? Well, at the end of World War II, the industrial capacity of all our competitors had been conveniently destroyed. We were the last economy left standing. We had created a huge industrial capacity to produce wartime goods and services. So what we did was we loaned lots of money to all the countries who had been destroyed so they could buy products. Then we converted our wartime capacity to a peacetime capacity. So instead of making guns and planes and tanks and bombs, we made cars and trucks and refrigerators and prefab housing. We can't do that today. We're not in an economic position. Who is doing that today? China, exactly right. So the role has been reversed. And so here is an oversimplified version of why things are going to change very dramatically. The Chinese want their money back. And we have to figure out a way of paying that money back to them. And we can't do that unless we figure out a way of reducing healthcare costs. So McKinsey, this global consultancy, did a really interesting study where they looked at every nation in recorded history that has accumulated debt loads similar to the ones we currently have. And they said, the ones who got out, how did they do it? And they said there are basically only 3 ways out, and 2 of them are unthinkable. The first one is you default on the debt. I borrow money from you. When it comes time to pay you back, I say, I'm not going to do it. Nah, what are you going to do about it? And you say, all right, I'll tell you what I'm going to do about it. I'm never going to do business with you again. I'm going to tell all my friends not to do business with you again. No one's ever going to loan you money again. We're not going to pay any attention to, your issues or your concerns. You not only will no longer be a leader at the table of nations, you won't even have a seat at the table of nations. So the consequences of default are really quite devastating, both internationally and also in terms of the impact on our standard of living. So if you don't want to default, what's number 2? Which is only slightly less desirable, and that's hyperinflation. You print lots and lots of money, and so I borrow, let's say I borrow $1 million from you, and then 5 years later I pay you back the $1 million. Nominally, I'm giving you the same amount of money I borrowed from you, but in terms of purchasing power, it's worth only $200,000, when you loaned it to me. So we can try to inflate our way out of the debt, but we'd have to have levels of inflation we've never seen before in America. I mean, levels of inflation approaching Weimar Republic in Germany in the 20s, or Zimbabwe about 3 years ago, where they had, in both of those countries, they had 6 or 7 week periods where prices doubled every day, literally. And so, I mean, just absolutely staggering. So the consequences of hyperinflation only slightly less desirable than the consequences of default. So if we don't want to default, we don't want to hyperinflate, what does that leave us with? And that's what McKinsey calls belt tightening. We as a nation suck it up, we cut spending, we raise taxes, we cut services, we break promises, we rewrite social contracts, and we slowly, painfully claw our way out of that deep, dark, recessionary, debt-ridden hole that we as a nation have got ourselves into. We voluntarily lower our standard of living to a threshold of pain, but above where it would be if we hyperinflated or if we defaulted. And that's what we're in the early stages of doing now. The big debates in Wisconsin about public employee pensions. Around the country you see teachers being laid off and police districts being merged, and Illinois, where I live, just raised Illinois income tax by 67%. So you're beginning to see the early stages of belt tightening. But you cannot consider belt tightening unless you consider health care. So that brings us back to the discussion that we talked about before. You cannot consider belt tightening unless you consider Medicare, Medicaid, and the Republican budget that was just proposed, which is in the newspapers today, has huge cuts, $6 trillion cuts over 10 years in the entitlement programs of Medicare and Medicaid. And so you're beginning to see the initial discussions, which would have been unthinkable just as recently as the last election. In the last election, and in the debate about health reform, my favorite picture, was of elderly protesters holding up signs saying, "Keep the government out of my Medicare," which to me was a marvelous irony. But the notion of you can't touch it. Well, all the stuff that was untouchable, that's exactly the stuff we have to look at if we're going to tighten belts and address getting the deficit down to manageable levels. So the question is not will it be done, the question is how will it be done and who will do it, which then cycles us back to the issue of the health reform legislation. So Congress now, our political leaders, said, I get it, I understand. We don't want to default, we don't want to hyperinflate, I get it, we have to belt tighten. So the members of Congress said, I understand how to do that. I understand how to raise taxes. I understand how to cut services. I think I can figure out how to break promises. I can do that. Well, here's what I don't understand. How can I do that and get reelected? All right, tell me how I can do that and get reelected. And that's what brought everyone's attention to health care, because Congress, in fact, and I want you to understand, all the Republicans who are saying health care should be repealed and replaced don't want it to be repealed and replaced. They want it to go through, but they want to be able to blame the Democrats. And it's really important that on both sides of the political spectrum, they're very strongly influenced by this data. So what brought their attention to healthcare? Figures like this, which said, for example, 30% of what we spend every year on healthcare adds no economic value whatsoever, and oftentimes injures patients as opposed to helping them. And so 30% may be a fairly antiseptic figure, but look at it, in terms of the impact on GDP. 30% of $2.7 trillion is 5% of our annual gross domestic product. Now that really got Congress's attention. They said, you mean to tell me if we can force healthcare to get more efficient, to pull out that 30% of waste, that will free up 5% of gross domestic product. That goes a long way toward, number one, belt tightening and easing the economic pressure that we're facing. Number two, I won't be the bad guy. We can demonize healthcare and make them the bad guy. Tell me more. And that's what, that's basically one of the things which pushed health reform over the finish line legislatively. The rhetoric aside, everyone wants to, make the tough decisions without being blamed for it. And if I can free up 5% of GDP without raising your taxes, without cutting your services, and scream and holler while it's being done, claiming that I think it's a bad idea, it puts me in a fairly good situation. So many people in healthcare will say, I'm sick of hearing this. I keep hearing how it's full of waste. Where's the waste? And that's the problem. $1 of waste, is a dollar of hospital employee salary. It's a dollar of insurance worker salary. It's a dollar of income for a physician. It's a dollar of margin for a hospital. It's even a dollar of revenue for a consultant, which I think pushes it too far. I think there need to be reasonable limits, by the way. And so that's part of the problem, is that when you look at this, we're wasteful for a variety of reasons, but not the least of which is in healthcare, everyone gets paid more than anywhere else. And healthcare, we get paid more than anywhere else in the world. And so one of the things that means is to do this is that everyone who works in healthcare is going to be making less money. That there'll be fewer hospitals, that there'll, and all of these issues and pressures. But so what are some other examples of inefficiency? And that brings us to one of the issues about governance, and that is in the reimbursement system. Things which we as physicians and hospitals are rewarded for today will be punished for tomorrow. So for example, there are about 4.4 million hospital admissions every year are completely unnecessary. And if we get rid of those, we'll save about $30 billion. That's great, but that $30 billion of savings is $30 billion less than that hospitals will get, which will make it more difficult for them to operate. So things which we're rewarded for today, we're going to be punished for tomorrow. And what's another example of how the reimbursement system is going to change? Take a very important issue, end-of-life care, and how much we spend for that. Look at the coasts, UCLA here in California and Johns Hopkins in Maryland. Average cost for someone who is dying, you're not trying to cure them. You've got them in hospice. You're trying to give them a good quality death. Average cost per patient in UCLA and Hopkins is about $90,000 per patient. Look in, and this is a little bit cloying, because you could say, well, look in the center of the country. It's not really the center of the country so much as it is a differently organized healthcare delivery system. Mayo Clinic and Cleveland Clinic, average cost per patient for end-of-life care is about $55,000. with no difference in outcomes. Both patients die. I don't mean to be facetious. No difference in the patient or family perception of the quality of their death. No difference in the satisfaction with the degree of pain palliation. The only difference is in $35,000 of cost. And we've tolerated these huge disparities for 30 or 40 years, coming up with fascinating excuses to justify them. And the one that I've heard to justify this is, well, the cost of living in California and Maryland is higher than the cost of living, you know, in Minnesota or in Ohio, so therefore the cost of dying is expected to be higher as well. I mean, ridiculous comments like that, which make no sense whatsoever. So it's also important to understand something else which was very subtle, but which pushed health reform over the finish line. And that is, we finally came up with good data which shows the high degrees of variation of performance in this country. Previous to that, we didn't really have it, and we had this belief. In fact, there's this kind of knee-jerk belief. I'll give you an indictment of the American healthcare system, and you give me the classic defense. Here's the indictment. We've got the most expensive system in the world. What was the classic defense? But it's the best. It's the best in the world. Now, we had no data to show that it was the best, and in fact, we'd use a tautological argument. I'd say, well, how do you know it's the best? Because it's the most expensive. Oh, okay. Well, clearly, if it's the most expensive, it's the best. Well, in the 90s, the Clintons got data that showed we're not the best. You know, we got World Health Organization data and other data that showed other countries spend far less on health care than we do and get better outcomes. They live longer, they have lower infant mortality, you know, they're basically better in everything except one thing. There's one thing we excel at in the United States healthcare system, and that's what could be called rescue care. High-tech, interventive, pull out the stops, bell and whistle rescue care. You know, if I'm hit by a car, if I have multiple organ failure, I want to be in the United States. If I have an esoteric illness, I want to be in the United States. But by any other measure, longevity, infant mortality, maternal mortality, public health, we don't rank very well. And the Clintons expected that to be sufficient. But what they didn't count on was the incredible, you know, solo-ipsism and cultural isolationism of America. You know, the Clintons said, look, the French spend less than we do, get better outcomes. You know, the Germans, the English, the Norwegians, the Japanese all spend less than we do and get better outcomes. And how did we respond as a nation? We said, well, that's great for them, but we're not like them. Don't try to make us be like them. Have you ever been to, you know, France? The people are so nasty in Paris. And have you ever been to England? The food is terrible, and they have horrible teeth. I mean, and the Norwegians, they're so dour and suicidal. And the Japanese, they're automatons and robotic. We are not like them. Don't try to make us be like them. And there was a major cultural resistance to comparing us to other nations' healthcare systems. Well, what's interesting now is what happened was a reliance on internal U.S. data and the high degrees of variation, like the one I just pointed out to you, in the American healthcare system. So yes, we as a nation aren't very good. But what's really interesting is there are pockets of this country which are very efficient, low cost, high quality. And if all of us in the country could perform at that level, we would be the best in the world. And that became a very important selling point. Suddenly it wasn't, we don't want you to be like the French. We don't want you to be like the Brits, you know, or the Norwegians. We want you to be like the best of the Americans. You know, and that was like, well, gee, if someone else in this country can do it, so can I. Well, give me an example of who some of these best that you're referring to are. El Paso, Texas. Ooh, no, I don't want to be like them. You ever been to El Paso? No, I don't want to be like them. Okay. Minneapolis, Minnesota. No, don't want to be like them either. They're basically, you know, transplanted Norwegians. Don't want to be like them. All right. How about Seattle, Washington? No, it rains all the time. All right. Well, the point is, though, we can find a market that is culturally, you know, and economically enough like you that you can say, gee, if they can do it, so can we. So, for example, look in the state of Montana. I'm doing a lot of work in Missoula, very inefficient, you know, kind of all over the map, you know, quality very variable. Billings, Montana, incredibly efficient, incredibly good quality. And if I try to compare Missoula, Montana to El Paso or Minneapolis, you get the reaction I just gave you. But when I say, gee, look what they're doing in Billings, you know, the people in Missoula say, wow, if they can do that in Billings, we can do that in Missoula. We're the same people, you know, it's basically the same culture, it's the same environment. Same is certainly true in California, huge degree, you know, of variation in terms of cost and quality in different markets in this country. And that was one of the things which really pushed it. Now, you can still hear echoes of this cultural solo-ipsism and criticism of the health reform bill, European socialism. All right, you know, that's an example of trying to conjure up the don't try to make us be like other countries. But what's really going to drive it is this. We're going to identify, and the government and the private payers will identify variation. And if they say, look, you're doing something and someone else is doing something, and you're doing it for 30% more than they're doing it, and your outcomes are no different, we're going to reset your level of reimbursement here. So go back to end of life. The only difference here is $35,000 of cost. So what's going to happen is they're going to say, okay, look, let's just pay everybody $55,000. and then we'll start ratcheting down from there. So the notion is going to be, if someone else can do it in this country better or less expensively than you're doing it, why should we pay you more? And then you'll get all that, but we're different, our patients are sicker, you don't understand, and that stuff is going to go away. That protected us for many years, and now it's going to go away simply because, if it doesn't, it'll break the system. So that's some background to it. And then as we think about health reform, it's very tempting to fall into the stirrers of the pot who like to create polemical and polarizing debate and discussion. And there were a lot of contentious issues in the health reform debate. Death panels, abortion, individual mandates, stuff like that. But if you kind of take that away, what you're left with are the areas of great consensus, where liberal Democrats and conservative Republicans agreed on the same concept. And here are the things which they agreed on, and regardless of whether it's legislatively driven reform or market-driven reform, this is the type of change we're going to see. Why are we so inefficient? And the answer is because we're rewarded for being inefficient, because our reimbursement system is based on volume. Physicians and hospitals make money by doing things. The more they do, the more they make. No one makes money by not doing something. All right? No one makes money by saying, gee, we'll do one test on you instead of 3. Which way does a hospital make more money? 1 test or 3? All right, 3. Okay, so we're incentivized to do stuff. And if you incentivize a system to do stuff, you're going to get lots of stuff done. And that's the system that we've had, high degrees of volume. The more we do, the more we make. All right? So I was in my ophthalmologist office recently, and they're under a lot of economic pressure, and his office staff was saying, well, gee, what we like to do now is a 2-visit model, where we comes in, looks at your eyes, and then you come back in 4 weeks later just to see if there are any changes. How do you feel about a 2-visit? And I said, let me tell you how I feel about it. I know exactly what you're doing. What you're trying to do is what he used to do in 1 visit in 2, so you can bill twice. Let's just do it in 1 visit, shall we? The doctor's the expert. I know. But it's just an example of volume. So if we're going to change the model, if we're going to pull cost out of the system and create a better model, we have to change the reimbursement system. And so everyone agrees we've got to move away from a volume-based system to some system based more on value. Which is what should we be getting, all right, for that. And that means that the mechanism of payment has to change. So you see moving from volume to value, and therefore moving away from some type of fee-for-service-based system. Every time you do something, you get paid. Every time you do something, you get paid. Fee-for-service, to some different type of payment system. And this is where it's going to seem very similar to what we tried to do in the 90s. Now they're talking about bundled payments, which is similar to capitation but different, and I'll describe how in a few minutes. And if we change the payment system, that then will force all the different disorganized, siloed pieces in the healthcare delivery system to reorganize themselves to come into compliance with the incentives of the new payment system. And that then brings up what's referred to as accountable care organizations, which are in the news right now. Not just hospitals and physicians working together, but hospitals and physicians in federally qualified health centers and nursing homes and subacute and rehab and hospice, all working together, not to take care of the patient in the most expensive, most intensive environment, which is what we're rewarded for under a volume-based system, but rather now to start thinking about how can we take care of the patients in the least expensive, least intensive environment. So it's a very, very significant change. So those are some of the big, big movements. Change the theory of the reimbursement system, change the payment mechanism. That will force the delivery system to reorganize itself. So it's very important to understand that the health reform legislation really doesn't say, hospitals and docs, you must behave this way. What they're saying is, we're not going to tell you how to do that. We're just going to change the way you get paid and get the same result. So we're just going to change the payment system. You will then have to change the delivery system. And it's important to understand, and see many people who believe that if health reform goes away, we'll go back to doing it the way we've done it before. That's not going to happen. I'll give you two quick examples. 3 months before health reform passed in January of last year, the government changed the reimbursement system for certain specialty physicians, cardiologists in particular, under a very complex formula called the RVU, Relative Value Unit formula. When there's an expense RVU, a work RVU, a malpractice RVU, then there's a multiplier. It's just marvelously complicated. So they just put a little tweak in that. And why did they do that? Because their goal is that they understand if you have independent hospitals and independent docs and no one talks to each other and they have different information systems, that generates inefficiency. So one of the goals is to drive hospitals and physicians together. So even if health reform goes away, my point is they can do that by tweaking the existing reimbursement system. So the cardiologists, who used to be the most free-range, independent, don't tread on me physicians. I would never work for a hospital. I want to run my own practice because I'm making lots of money. They just tweaked the relative value unit formula for their reimbursement and made it impossible for them to earn a good living. Their reimbursement took a 30% cut across the country. Why? Because what they did was they could significantly reduce the incentive for what's called ancillary services, tests. And in their case, cardiologists did a lot of nuclear scans. And so if I'm a cardiologist and I bring you in and I've got a scanner in my office, and I say, gee, you need a scan or you need a stress test or something like that, and I can do it in my office, you think how marvelously convenient, and you don't realize I'm making money off that, and so therefore I've got an incentive to offer those, an economic incentive. The government said, and they would say, well, we would never offer a test, unless it was clinically necessary, and that was the big argument. The government said, well, let's see, we'll make it so that you cannot, make a penny on ordering those tests anymore. And suddenly they stopped ordering the tests. It was absolutely fascinating. So much for clinical necessity. Not only that, but then the cardiologists, what happened was these were the most free-range independent docs, as I said. Now suddenly it's raining cardiologists all around the country. And so now around the country, hospital executives found cardiologists knocking on their door saying, wouldn't you like to buy my practice? Oh, and by the way, I've got a nuclear scanner I can sell you cheap too. And that was just one tweak of the reimbursement system, just one tweak. So please understand, if health reform goes away, the goals of driving hospitals and physicians together and the goals of pulling cost out of the system and changing the incentive system can be encouraged just by subterranean tweaks in the existing reimbursement system. For hospitals and for imaging centers, I'll give you one that just happened 4 weeks ago. If you're in the hospital or you go to see a doctor and the doctor says, let's see what's going on with your abdomen, let's do an abdominal CT scan. And if the physician said, let's also do a pelvic CT scan while we're at it. So you're on the table, and the CT scanner, all it has to do is go down another 8 inches. No big deal. But those were 2 different billing codes called CPT codes, current procedural terminology codes. And so what would happen all the time is, while we're at it, do a pelvic, or while we're at it, do an abdominal, and you get to bill twice for the same procedure, make a lot of money. Well, 4 weeks ago, they said, can't do that. They're not 2 CPT codes anymore. There's one, pelvic abdominal CT, and you only get paid once. And to give you an example of the implications that has for a freestanding imaging center, that'll cost them about $15 million a year. For a hospital the size of Natividad, that's probably going to, I don't know if Harry's crunched the numbers yet, but that's probably going to be about a $1.2 million reduction in reimbursement to the hospital, just with one little stroke of the pen. So those are just 2 examples, independent of health reform. So the thing I'm really trying to get across to you is some of us really are opposed to health reform and think it's outrageous and think once the bill is repealed, everything's going to go back to normal. No, it's going to be a new normal. And even if health reform is repealed, the driving force is still going to be in play, and we're going to see tons of money being pulled out of the system, and it's going to make it very difficult for us to operate anywhere near the way we used to operate. We're going to have to not do what we're doing now incrementally better. We're going to have to figure out ways of doing it fundamentally different. And that's always a great challenge for leadership. And so that kind of brings us to the point of the discussion. So then a couple of other issues, and here's one example, especially for those of you who don't live or work in healthcare, to show you the perverse incentives that we have. Readmissions and poor quality. You may be surprised to know that a hospital makes money when it injures you. All right, so let's say I'm a patient in a hospital. The hospital gives me an infection. The hospital operates on my wrong body part. It causes me an injury. It then must treat the injury that it caused. It gets to bill for treating the injury that it caused, and it makes money on that. Now, hospitals would always say, yeah, but we would never do that. Don't cast a negative aspersion. Well, how would you feel about that incentive system? How would you feel if I told you that every restaurant you ever go to gets a 30% bonus if they give you food poisoning? And each one of those restaurants will stand up with equal indignity, that the hospitals have and say, we would never. Yeah, but how do you feel about that incentive system? Weren't those eggs this morning just a little on the runny side? How do you feel about that? Okay? And so hospitals are rewarded for injuring patients. And I'll give you another example, readmissions. And see, all this is going to change under health reform. Right now, if you have a loved one who's in the hospital with congestive heart failure, and they're treated and they're released, and then 20 days later they're back in the hospital for congestive heart failure, the hospital makes money on that. They get to bill for that twice. All right? Well, under health reform, they're saying, no, if you're going to do your job right, someone's in the hospital, they shouldn't be back in the hospital within 30 days. And if they are, that means you didn't do something right. And so if someone gets readmitted to the hospital for similar conditions, the hospital won't get paid for that. And so that's an example of things which we're rewarded for now, we're going to be punished for in the very near future. And that's a way of pulling tons of waste out of the system. But the problem is it's going to require just tectonic changes in the way we organize our healthcare delivery and the things we take for granted. All the stuff we know to be true is now going to change as a result of that. There's also some really interesting political jujitsu going on. And you see combinations of legislative reform as well as market reform. Driven in the bill. So here's one example, is a great focus on transparency. The notion of it's not just legislative change, but it's also using the principle of the market that price and quality transparency drives improvement in the market. Right now we're price and quality opaque. How many of you in this room can tell me which hospital in Monterey County has the best quality and prove it, okay, with data? Whereas how many of you can tell me which car is the safest car to drive? Things like that. Okay, so the problem is we've been incredibly opaque in terms of quality, and even worse in terms of price. Any of you been to a hospital and wondered when the bills were going to stop? Or ever seriously, I was in a hospital in California a year ago. I had emergency admission. I got my last bill 3 weeks ago. From a hospitalization in January of 2009. And so my friends and I, whenever we have a hospitalization, always play a game. How much do you think it's going to cost? And you can't answer that question until when did you get the last bill? All right? So have you ever asked the question, how much is this going to cost? Well, years ago we said, don't worry. Why? Because your insurance would pay for it. And that's one of the things which created price and cost opacity. But now that you're starting to have to dig into your own pocket and pay more of your own money because of high copays and high deductibles, patients are now asking questions they've never asked before. How much is this going to cost? Do I really need that test? And frequently when you say how much this is going to cost, you're met with, oh, we don't know. Don't worry, we'll know when we're done. We're the only economic sector where that's the case. Would you accept that if you were buying a car or a bag of groceries? Can't tell you now, you'll know in 6 weeks. We'll see when you get the bills. Absolutely insane. And that's part of the inefficiency which generated tons of waste and increased the profits and increased the salaries in the healthcare system. So now the theory is very simple, and that's let's do what markets do. And this is this interesting combination of legislative change and market-based change. Let's release information on the cost and quality to the American public and to the payers. And if there are high-quality, low-cost providers, and if there are low-quality, high-cost providers, one of three things will happen. The poor providers will either get better, and everyone wins. They will be acquired by the better providers, and that's a lot of what we're seeing happening around the country today, is systems getting bigger and small hospitals being subsumed into larger hospitals. Or they will go out of business. And in any case, the system gets better. And so this notion of transparency, releasing information, is not something which is going to happen. It's happening right now. For example, Illinois just about a year ago released very good severity-adjusted data on mortality rates for hospitals. So in Illinois, you can press a button and get an accurate comparison of where you're most likely to die in a hospital. And the differences are amazing. So for example, for acute myocardial infarction, death after emergency admission in a hospital, the range is 1.5% on the low end to about 12% on the high end. And these are severity adjusted, meaning you can't say, gee, my patients are sicker, or I'm in a more compromised community, or you don't understand. No, we understand, and we figured out a way of making apples to apples comparisons. Now suppose you had access to that information. Would that influence where you went? That's a huge difference. And so that's that notion of we're going to release information and drive improvements in quality and reductions in cost using both legislative and market forces. And then a great focus on kind of waste, fraud, and abuse, and a few others. So these are the themes no one's disagreeing with. No one's going to argue, no, we want price opacity, we want poor quality, we want high cost, we want waste, we want inefficiency. Everyone sees it. So those are some of the big themes which are driving this. Now, the implications of all this are what? And this is something we're seeing kind of playing out in the field right now, and this is just a report from Moody's, who I like to use because they were so helpful to me during the recent economic crisis. But anyway, I digress. And they say basically, no, this is going to really be painful for hospitals because if we think about President Obama's goals in health reform. We want to pull cost out of the system, and we want to bring 30 million Americans into the system. We're not going to insure everybody, see, because that would be European socialism. So that was a really interesting thing. It's like, oh, don't worry, it's still America. There will still be a certain percent of the population that doesn't have health insurance. So it's still the good old US of A, which was a compromise based on what they learned from the Clinton program. If everyone was insured, that would be European socialism. So there'll be some, 5–10% of the population that won't have health insurance, so it's still America. So anyway, we want to bring 30 million Americans into the healthcare system, and we want to pull costs out. How can you do that? If you have a system and you add 30 million people to the system, how can you pull costs out of the system? It's impossible. No, it's not. It's theoretically possible. To do it, you've got to change the system. All right? If you don't change the system, then cost will go up. Absolutely no question. But if you can change the system, then theoretically it's possible you could bring more people into the system. Well, what Moody's is saying is the way they're going to change the system is going to take a lot of money to pay for it. Where's that money going to come from? It's going to come out of hospitals and out of physicians. Number one. Number two, what's the consequence of this? It's going to drive what we're seeing around the country, and California is already a little bit ahead of this, is massive consolidation. The notion of the standalone hospital, the community hospital is rapidly going away, just like the independent physician is rapidly going away. And California is a leader in this. You have one of the biggest healthcare systems in the country here, Kaiser, and you have large systems forming, and this Sutter, for example, a very large system, growing fairly quickly. And so this notion of consolidation, the notion of trying to figure out a way of rationalizing services and getting economies of scale by not having duplicated services and having central planning, is really picking up speed. And I've been in this business for more than 30 years, and I've never seen the degree of mergers and affiliation discussions and consolidations that we're seeing right now. I mean, everyone is talking to everybody else. And what's the reason for this? One of the reasons is because to make yourself relevant to health reform as a provider, it's going to take a lot of capital. You're going to need new information technology systems. You're going to need to be able to acquire physician practices. You're going to need to be able to push the boundaries so that you're not just a hospital. You're not just a hospital with physicians, but you've got federally qualified health centers. You've got nursing homes. You've got subacute long-term care, all those things. And so access to capital is going to be a big thing. Meanwhile, Wall Street is saying, we no longer are enamored of the nonprofit healthcare field. Just because you're a nonprofit, just because you're a governmental agency, just because you're doing the Lord's work doesn't mean you're a good credit risk. And Wall Street is saying, before we give you a credit rating, we want to see that you're A, a good performer, and B, you have a minimum threshold of revenue. And the threshold that they're using is $1.2 billion of annual revenue, which very few hospitals come anywhere near that. So some hospitals are merging with others just so they can create the large revenue base, which will give them access to capital. And Wall Street's saying, we want to see you be profitable. We've got to have at least a 3% margin, and you got to have sufficient money flowing through you in order to be worthy of an A rating. So that's one of the things we expect to see is a lot of system formation, which we saw in the 90s. But we're going to see this is kind of the second and more aggressive wave. So what are some of the implications for this? And here's where the current Republican proposal for the budget is really quite fascinating. First of all, for those of you who aren't in healthcare, hospitals have basically 4 buckets, of payers. There's indigent care, people who don't have insurance and don't have money, who need charity care. And safety net hospitals like Natividad, tend to take care of these people with a disproportionate share compared to private hospitals. There is Medicaid, or as you call it in California, Medi-Cal. Hospitals, take care of a fair number of them as well. Then there's Medicare, and then there's private pay commercial. Now, it used to be we made money on private pay, we made a lot of money on Medicare, and we lost money on Medi-Cal, and we lost money on indigent care, but we could shift the costs and shift the losses and cross-subsidize from the profitable buckets. Now, we're not making money on Medicare. So the average hospital in the country loses 13 cents on every dollar of care it provides to a Medicare patient. So now you lose money on the indigent side, you lose money on the Medi-Cal side, you lose money on the Medicare side, and we try to make enough on the commercial side to cross-subsidize the losses and still have enough of a margin left over. The problem is Medicare losses are going to start skyrocketing for 2 reasons. The aging of my cohort, the baby boom. So every day, right now, there's something like 4,500 Americans are turning 65. What's significant about that is 4 years ago, that figure was 2,500. In 4 years, it'll be 7,500 a day. So Medicare would fall apart just because of the age wave. Secondly is the reduction, the tweaks in the pen that the government is doing. So now many hospitals have a mantra, which is if you can't make money on Medicare, you can't stay in business. So right now, hospitals are losing 13%. They have a negative margin of 13% every time they treat a Medicare patient. And Medicare is going to start cutting its reimbursement, and you're going to see more people in the Medicare system. So hospitals are trying to figure out, wow, in order for me to stay alive, I've got to get much more efficient. And that's part of that notion of driving efficiency and driving quality. And a lot of hospitals aren't going to be able to do that. So the whole hospital business model is very threatened. Now, that's a general model. Natividad has a different model. You have a waiver. You get paid a little bit more on Medi-Cal because you're a safety net hospital. So there are a few things that make it a little bit different for you, but the same pressures are going to be in existence. So the predictions are, the cost shifting is going to become very, very difficult. It's going to be very, very difficult, to stay in business, unless the hospital gets much, much more efficient, which then means it's got to behave very differently than it's behaved in the past. So, and this is going to surprise you, but that's the big picture stuff. Now come the details. So I'll try to go through the details fairly quickly and at a very high level, not to bore you with it. But just let me pull. I just pulled 4 or 5 things out of the bill to give you specific examples of what I'm talking about. So here's one, and this first one I've referred to as readmission rates. So starting in October of 2012, so less than a year and a half. Hospitals, anytime someone gets readmitted within 30 days, the hospital won't get paid for them, number one. Number two, if their overall readmission rate is higher than a certain expected average, they'll get a 1% across-the-board reduction in all of their Medicare reimbursement. In the second year, it'll be a 2% reduction. In the third year, it'll be a 3% reduction. This is an example of, number one, hospitals being punished for things they used to be rewarded for. Number two, pulling money out of hospitals in order to try to reduce the deficit, and secondly, pay for 30 million Americans coming into the healthcare system. So look at that bottom line. It says that the Congressional Budget Office says that doing this will save about $7 billion over the next 10 years. That means hospitals will get $700 million a year less just on this issue of readmissions than they had been getting. All right. Now, why would they focus on readmission so much? Anyone know what the 30-day readmit rate for Medicare patients is? This shows you what a policy wonk I am. I live with these kind of statistics. 19.6% of all Medicare patients are readmitted to the hospital within 30 days. 28% are readmitted within 60 days. 54% are readmitted within 1 year. Something's wrong. Okay, now hospitals will say that's not our fault, they're non-compliant patients, they're not taking care of themselves the way we told them to take care of themselves, they're not taking their meds, and that's what we're very good at, is a blame the patient strategy. Okay, and now what the system is going to say is, well, you better figure out a way, of keeping them healthy so they don't come back in the hospital, because if they come back in the hospital, we're not going to pay you for it. And so that's a very good example of kind of changing the model. Look at the second one, because this gets to the issue of quality. Hospitals that meet performance standards set by Health and Human Services on at least 5 quality measures will get a pay bonus. Now, for hospitals, that would be really cool if there was a period right there. But there's not. It goes on to say, from a pool of funds collected from all hospitals. What does that mean? It means hospitals are going to be competing with each other. So it's not just legislative change. It means, what it basically means is, all of you, let's say all of you in this room were hospitals, all of you are going to have some of your money withheld that's going to go into a pot. And only some of you will get that money back. The highest quality performers will get it back. And it's going to be very interesting. So, what that means is there are going to be winners and losers, and it's going to be very crowded at the top. It's kind of like you were in your high school and you didn't pay attention to your guidance counselor and suddenly found yourself signed up for advanced placement physics. And there are 3 geniuses in the class, and the professor grades on the curve. And an 85 on the test is an F. All right? And a 90 on the test is a D plus. So now suddenly what was acceptable, our quality is good. And that was always fun if you talk to hospitals. What's your quality? They go, good, good, oh, good. Well, how do you know? Well, just look, we have an atrium, really good. Or we have a banner, we got some award from someone. Yeah, big whoop. Now it's going to be, show me your outcomes, show me your statistics. What are your mortality rates? What are your complication rates? What are your infection rates? And that then brings you to the next point at the bottom. Hospitals with what are called HACs, hospital-acquired conditions, wrong site surgeries, catheter-associated bloodstream infections, ventilator-associated pneumonias, things like that, post-operative surgical infections, the stuff that for years we said, that just happens. Well, it turns out it happens a lot. And we kill lots and lots of people, and I'll give you those statistics in a second. And now the government's saying, instead of rewarding you for that, if your rate is high, you'll get punished for that. And so here's an example where you see competition where no amount of improvement will save the bottom performers. What they're saying is the bottom 25% of hospitals will get an across-the-board 1% haircut in Medicare reimbursement. So if everyone gets better, you're still going to have 25% losers. And so you see these cuts in Medicare, in addition to all the cuts I've described in the health reform bill, hospitals are at risk for up to 12% of their across-the-board Medicare reimbursement for issues like this. And then, starting the very next year, when the 30 million Americans come into the Medicaid system, into the state insurance programs, it'll expand to that program, and this will be released to the public. So hospitals' harm rates will be released to the public, and their payment denial rates. So you'll be able to get online and look up, what was this hospital's harm rate compared to that hospital's harm rate in severity-adjusted data. And that's an example of using the market to try to reform the system. Now, now's a good time to stop and make a point. Many people, especially the physician population or hospital executives, when I make this presentation, will stand up and say, well, guess what? There aren't going to be, what's going to happen when there aren't any hospitals? Or there are not going to be any physicians to take care of patients. Well, let's take the physician issue first. Physicians, especially physicians my age, who are incensed, at what they think is, total corruption of their profession, are convinced that there will be no physicians to take care of us in the future. And we're going to face a big physician shortage. But look at the data. Last year, law school applications decreased by 12%. MBA school applications decreased by something like 7%. Medical school applications increased by about 15%. And that's after we opened 3 new medical schools in this country. Why? Because in the economic crisis, kids have said, gee, my older brother who's a lawyer can't get a job. My sister who's an MBA can't get a job. I don't see any unemployed doctors. They may not be making as much, it may take them years to pay off their debt, but I'll always have a job if I'm a doctor. So I'm not persuaded by the argument that this is going to make people stop going to medical school just because the data shows otherwise. But the other view is, from the hospitals, well, there won't be a hospital in this community. So what? It's important to understand that that might be one of the goals of this. We have what's called, this is a perversion of John Say's law of economics. Supply creates its own demand. All right? And so I'll do this Socratically. What's the number one predictor of how many surgeries are performed in any community? The number of surgeons in that community. What's the number one predictor of how many MRI scans are done in any particular community? Number of MRI machines. What's the number one predictor of how many CAT scans are done? The number of CAT scan machines, and on and on and on. It's not based on what's the need. It's based on what's the supply of healthcare professions. So if you want to eliminate the number of surgeries in a community or reduce it, if you get rid of some of the surgeons, the number of surgeries will go down. If you want to reduce hospital costs, if you close a couple of hospitals, the hospital utilization will go down. And so everyone who says they're going to destroy the American healthcare system, that's part of the plan, is we have oversupply. And again, I emphasize to you, this is not something which is going to happen. This is something which is happening. I can take you to communities in California where there used to be a hospital 10 years ago, and there isn't today. Okay? I can take you all around the United States where that's the case. Now, in some communities, it's, well, big whoop, that means I need to drive another 15 minutes. But there are parts of the United States where people have to drive a couple of hours to get to a hospital, whereas 20 years ago there was a hospital in their community. And so we can't take it for granted. So in Monterey, there are 4 hospitals, if I'm remembering correctly. And so you're tempted to believe, well, we'll always have 4. Well, suppose there are only 2. So an interesting question is, how many do you need? Not based on old measures, but based on new measures. And if we don't use the hospitals as much, if we can push the care into the clinics or the outpatient environments, and we don't do unnecessary surgeries and unnecessary, intensive care admissions, how many do we really need? And that's an open question which no one can answer. But please don't think it's a given. We've always had a hospital, so we'll always have a hospital. There have always been 4 hospitals, so we'll always have. We can't get along without 4 hospitals, because you'd be amazed at how things have changed. In fact, right now, we were talking about this before the session began. In Monterey County, you have about 1.1 beds for every 1,000 people in the county. And that was a measure we used to use of capacity, beds per 1,000. And we were taught, people my age were taught that you needed a minimum of 4 hospital beds for every 1,000 people, in the community. And that was in existence for years. Then as the reimbursement system changed, the capacity demand measure changed along with it. And so you're at 1.1. I can show you markets where there are 8 beds per 1,000 in this country. I can show you markets in California where there are 0.5 beds per 1,000 in this country. So you're by no means overbedded compared to the worst, but you're by no means the most efficiently bedded compared to the most efficient markets in this country, some of which are in California, by the way. And, you go further south and you'll see 0.5, 0.6 beds per 1,000. So all of this is going to be up for grabs. But what it basically means is things we know to be true actually are assumptions. And they're based on 30 or 40 years of the way things work. But now when you change the underlying principles, those assumptions begin to go away. All right. So having made those points, let me zip through a couple of other points and and emphasize this. Here's this notion of bundled payment. And what is bundled payment? How is it different than capitation? And please don't let me do this for more than 30 seconds because this gets real policy wonky real quick. Capitation, is something we tried in the 90s. You tried very hard in California and didn't quite work. Why? Because it gives providers what's called actuarial incidence risk. So let's say I'm a hospital and you're the community in Monterey. Under capitation, I'll get a payment from you. And in exchange for that payment, I have to take care of everything that goes wrong with you for a 1-year period. Now, for me to set the payment, I've got to make a prediction of the incidence of risk. I've got to look at you and say, how likely is this population? How many of you are likely to get sick with this? How many of you are likely to get sick with that? How many of you are likely to get hit by a car? What could go wrong? And I've got to make a prediction. And if I'm accurate, I've got a chance. If I'm wrong in my prediction, I get blown out of business. Not because I wasn't an efficient care provider, but because I wasn't accurate in my actuarial prediction of risk. And so capitation, we weren't ready for. We went from Wild West fee-for-service to an initial form of bundled payment called DRG, stands for Diagnostic Related Group, based on the prospective payment